In terms of monitoring and supportive care, the core temperature should be maintained 36.5 to 37.5. I will request you to review my playlist on thermoregulation where many of these aspects are covered. IV fluid 70 to 80 ml per kilo in a humidified incubator with close regulation. Again, I have a lecture on fluid management in the small babies, including feeding. I'll refer you to that. Parenteral nutrition should be started from birth. There is no doubt that adequate nutrition from the beginning is very important. Amino acids, we start actually with 3 grams from day one. Lipids start with 1 to 2 grams and increase quickly. We don't usually exceed 3 grams to 3.5 grams of lipids, but maximum 4 can be used if there is growth issues. Amino acid, we go up to 4 grams in most of the small babies. Enteral feeding with mother's milk should be started from the first day if the baby is hemodynamically stable, and that would mean if the baby doesn't need inotropes or is not hypotensive. So trophic feeds early on is best, and as soon as the baby is stable, you can start progressing at the appropriate rate. Again, the video I mentioned on feeding and fluid balance covers all these. In infants with the RDS, the antibiotics should be used judiciously and stopped early when sepsis is ruled out. If you are going through this and you have any concerns finding the videos that I'm talking about, you can just comment and I can share the link immediately. In terms of cardiovascular support, treatment of hypotension is recommended when there is evidence of poor tissue perfusion, such as oliguria, acidosis, and poor capillary refill. So the reason they are mentioning this is the concept of not going by the exact numbers. Of course, functional echo, if you are able to do it by the bedside, it would guide you on how to approach it. And in terms of PDA treatment, again, you can refer my video on PDA treatment, a pragmatic approach as well. So paracetamol, they suggest when there is thrombocytopenia or concerns about renal function. And actually, I support the Iowa approach where paracetamol is the first line in the small babies. Invariably, there is a concern about renal function in all the tiny babies, and paracetamol has been shown to be reasonably safe. As I mentioned earlier in the comment on steroids, the long-term neurodevelopmental effect is probably a temporal and an association than an effect. So you don't need to be worried about it at this stage. So we will be waiting for further evidence, and unfortunately the Benedictus trial and the other studies did not give any clear verdict on ibuprofen. So the Iowa approach, there is evidence coming out as well from a first study as well that the exposure to the shunt is important. By reducing it, you may be helping these babies. So in the tiniest babies, treat the PDA early, start with paracetamol, and if paracetamol doesn't work after the first week to 10 days, you can go for ibuprofen. In the bigger babies, you can consider a higher dose of ibuprofen as well. The thresholds for red blood cell transfusion is set at 12 grams for those with severe cardiorespiratory disease, 11 grams for those who are oxygen dependent. For stable babies, they have put a cutoff of 7 grams at beyond 2 weeks. I don't agree with it. It depends on the gestation of the baby. In the tiniest babies where they are well off the mark of producing their own red cells, which you would expect by 6 to 8 weeks when the nadir is persisting, these babies are far off. So in the smallest babies, you would probably use a threshold of 8 to 9 grams if they're off oxygen in the first 3 to 4 weeks of age. And remember the evidence that the lower the hemoglobin goes, there is a possible risk to the brain as well as the increased risk of NEC. Transfusion associated NEC may be related to the lower level of anemia that we accept. So in babies at highest risk, so I don't know how this got passed as beyond 2 weeks, you put it at 7 grams. So again, the purview of this guideline doesn't need to include points like this which are controversial. So again, I would caution about this point. Surfactant can be used for RDS complicated by congenital pneumonia. Again, surfactant can be used to improve oxygenation following pulmonary hemorrhage, and surfactant can improve oxygenation with severe meconium aspiration. So there is no real change in these guidelines. So that's the last slide, and obviously, like in any guideline, a guideline has to support your management. There are reasons for modifying the guideline locally, and as I said, thresholds like this which you have to be cautious about. Maybe for a baby above 4 to 6 weeks or a bigger premature baby, you can apply this. So don't assume that just because it's in a guideline, everything is suitable for your use. You have to look at the evidence from your own perspective. The guideline obviously supports you, but you have to be cautious in how you use a guideline. And the point I made in the beginning about market sponsoring, again, is something to consider in a guideline which is widely used in the neonatal circle. So thank you for watching, and do